The topic is crystal induced Synovitis. These are diseases where there is a deposition of micro crystals in joints leading to various disease manifestations. And if the microcrystal is uric acid, the disease is known as gout. And if the microcrystal is calcium pyrophosphate dihydrate, the disease is known as pseudo gout. And if the deposition of hydroxy apatite and other basic calcium phosphate complex, then the disease is known as apatite. Gout is the most important among these diseases. So few words about gout. It is more common in men than women, and usually there will be a family history. Now coming to etiology of gouty arthritis. You see, etiology can be divided into two types, primary and secondary. In primary, the main cause is under secretion of uric acid in urine is the main cause. For secondary, it can be further divided into mainly three. There can be under secretion, there can be overproduction, and there can be certain situations that induce hyperuricemia in blood. So what are the secondary causes that causes under secretion? It includes renal disease, aspirin, and ethanol. In secondary cause of overproduction, it involves myeloproliferative disorders, polycythemia, hemolytic anemia, and cyanotic heart disease. You see, in all of these diseases, there is rapid or more degree destruction of cells which have this DNA and RNA, and this contains the side product as uric acid. Those involving induced hyperuricemia involves acidosis. So the main cause of acidosis that we can see like starvation, diabetic ketoacidosis, lactic acidosis can also induce hyperuricemia. Then it can also be seen in dehydration and in pre-eclampsia. Coming to etiology of pseudogout. The etiology of pseudogout includes old age, advanced osteoarthritis, neuropathic joint, gout, hyperparathyroidism, diabetes mellitus, hemochromatosis, hypothyroidism, hypomagnesemia. See why I am discussing all these etiologies, because while treating pseudogout you also have to treat these conditions as well, otherwise the patient will have recurrence of pseudogout. Now coming to clinical features. The general rule is this: if you are seeing a patient with acute attack of monoarthritis, we will suspect gout. If you are seeing a patient with chronic polyarthritis, we will suspect mainly these two diseases, either rheumatic arthritis or osteoarthritis. This is the general rule. Now coming to clinical features of gout. As far as clinical features are concerned, gout has mainly three phases. One is asymptomatic hyperuricemia. Second is acute arthritis, and third one is chronic arthritis. In asymptomatic hyperuricemia, the main feature is the uric acid level will be more than 7 milligram per deciliter, and as far as treatment is concerned, we do not intervene unless there are two situations. That is, when the uric acid rises more than or equal to 10 milligram per deciliter in females, and when it becomes more than or equal to 12 milligram per deciliter in males. So in asymptomatic hyperuricemia, the main thing is uric acid level is more than 7, and we do not give treatment unless the levels are this much in male and female. In case of acute arthritis, here single joint is usually seen rather than multiple joint. But please remember, a patient can present with multiple joint involvement also. However, single joint involvement is more seen, and there will be usually a history of precipitating factor, which includes alcohol, dehydration, fasting, or any recent surgery. In case of chronic arthritis, there will be a history of recurrent attacks, and on examination you can see some joint deformity. For pseudo gout, it can present either as gout arthritis, that is acute mono, or it can present as rheumatic arthritis or OA arthritis, that is it can present as a chronic polyarticular involvement. Okay, so how will you diagnose whether it's a gouty arthritis or pseudo gouty arthritis? Both patients can present with this acute monoarticular involvement. There we mainly study lab diagnosis. That is, we will aspirate the joint fluid and look for crystals in compensated polarized light. If there are crystals are there, and their we will examine for their shape and their birefringence. If the shape is needle and they have negative birefringence, then these crystals are urate crystals. If the shape is pleomorphic, that is variable shape, and they have weakly positive birefringence, then what you are seeing is calcium pyrophosphate dihydrate crystals, that is your pseudogout. Suppose you are seeing no crystals, there are no crystals in the fluid, then you have to examine the joint fluid in electron microscopy or mass spectroscopy. There you can see your hydroxy apatite and basic calcium phosphate complex. So summing up, you are seeing crystals in joint fluid. Yes, then depending upon the characteristics you can identify it as gout or pseudo gout. If you are seeing no crystals in joint fluid, then your diagnosis becomes apatite. Then suppose you are doing images of the joint involved, you can see there is erosive arthritis. And in case of pseudo gout, you have to do imaging of wrist, knee and pubic symphysis. There you can see chondrocalcinosis. In case of hydroxy apatite, the imaging will show a cloud-like deposits in periarticular area.